The next topic here is cardiomyopathy. So there are three main kind of cardiomyopathies. First, dilated cardiomyopathy, then hypertrophic cardiomyopathy, and the third kind is restrictive or infiltrative cardiomyopathy. So for the etiology of the three conditions, so first is the dilated cardiomyopathy. It is the most common cardiomyopathy, even it constitutes like 90% of the cases. So, the most famous cardiomyopathy is dilated cardiomyopathy. It has a lot of different kind of spectrum of etiologies. It is often idiopathic or familial due to mutation of a gene called the TTN gene. The TTN gene encodes for a sarcomeric protein called the titin. So this is the protein. This is the gene TTN gene. The protein is called titin or whatever. This is for the idiopathic or familial cause. The second, the drugs may cause cardiomyopathy. The famous drugs for causing cardiomyopathy: alcohol, cocaine, and doxorubicin. So alcohol and cocaine and the chemotherapeutic agent doxorubicin. And the infection, there is a very famous virus for causing cardiomyopathy, which is Coxsackie B virus, very high yield Coxsackie B virus, and a parasite called Trypanosoma cruzi, which is causing Chagas disease. So Chagas disease, Trypanosoma cruzi parasite, a virus, Coxsackie B virus, and the ischemia, of course, may cause dilated cardiomyopathy, such as coronary artery disease, and the different kind of systemic conditions which affect different organs, such as hemochromatosis and sarcoidosis. So hemochromatosis, and you have three different conditions: hemochromatosis, sarcoidosis, and amyloidosis. For the hemochromatosis and the sarcoidosis, they can cause dilated cardiomyopathy and restrictive cardiomyopathy. You will find here that the sarcoidosis and the hemochromatosis also cause restrictive cardiomyopathy, but amyloidosis only causes restrictive cardiomyopathy and it does not cause a dilated cardiomyopathy. This is for the systemic conditions: the cytotoxicosis and the with beriberi. You know that with beriberi versus dry beriberi, it is essentially a thiamine deficiency. So it is very characteristic for neurological lesion, but the with beriberi is much more famous for the dilated cardiomyopathy and its effect on the heart. So peripartum cardiomyopathy is also a kind of dilated cardiomyopathy. So this is for peripartum cardiomyopathy that occurs after or within the period of giving birth. So this is for the etiology, and for the finding, you know these are the typical finding of heart failure, SS3, systolic regurgitant murmur, dilated echo heart on echocardiogram. You know it's dilated cardiomyopathy. So if you do an echo, you will find dilated heart. This SS3 is very specific for dilated cardiomyopathy versus the S4, which is specific for hypertrophic cardiomyopathy. When we came for hypertrophic cardiomyopathy, you know it is very specific for S4. So SS3 for dilated cardiomyopathy and S4 for hypertrophic cardiomyopathy. And for the treatment, you essentially you don't want to put so much fluid in the circulation. So you restrict the sodium. First, you give diuretic, you give corticoid receptor blockers such as spironolactone. These are three measures to limit the fluid within the circulation: sodium restriction, giving a diuretic, and mineralocorticoid receptor blocker spironolactone. And again, then you give the patient ACE inhibitor or ARBs and beta blocker. And the sacubitril, which is ARNIA angiotensin neprilysin receptor antagonist. So and ACE inhibitor, ARBs, sacubitril, these are kind of the same. You give one of them, and along with beta blocker and all kind of different drugs that restrict the fluid in the circulation. And the long-term treatment is heart transplant, and you may give an intracardiac device for the patient not to go into sudden cardiac death. So this dilated cardiomyopathy leads to systolic dysfunction, and on you will find on histology, you will find sarcomeres added in series. So you sarcomeres, which is eccentric hypertrophy, versus in hypertrophic cardiomyopathy, you will find the sarcomeres which are added in parallel. So this is the sarcomere, and sarcomeres, they are added in parallel. They cause hypertrophy. This will cause dilatation. So this is elongated and dilated. So this is called the sarcomeres adding in series versus adding in parallel and causing hypertrophic cardiomyopathy. So this is dilated cardiomyopathy. So you compare that to athlete's heart where left ventricle and right ventricle enlargement facilitates increased stroke volume and increased cardiac output. You know, in athlete's heart there is a enlargement of the left ventricle and right ventricle, and it increases stroke volume and cardiac output to meet the needs of athlete heart. But here you have, on the other hand, the systolic dysfunction. So this is a comparison between it and the athlete's heart. So for the stress cardiomyopathy, very specific case called the Takotsubo cardiomyopathy, which is a broken heart syndrome. You know that the myth of the sadness, the effect on the heart. This is a very true. This is true that stress may cause an effect on the heart in the form of a ventricular apical ballooning. So the ventricle, you will find a balloon in the left ventricle. So this is called ventricular apical balloons. In the apex of the left ventricle, there is a kind of ballooning of the heart. This is due to sympathetic stimulation. So the sympathetic stimulation, you have a stressful condition, and the sympathetic stimulation is going on and on and on. The long term, you may have called Takotsubo cardiomyopathy, aka stress cardiomyopathy, or broken heart syndrome. So for the ventricular hypertrophic cardiomyopathy, in 60 to 70% of cases, autosomal dominant condition, mutation in the gene myosin binding protein C. You remember here for dilated cardiomyopathy, TTN gene, and the protein was called titin. Not very high yield, but just know that. And here most commonly due to mutation, the gene is called encodes sarcomeric proteins called myosin binding protein C and the more beta myosin heavy chain. So on the myosin, so myosin binding protein C and beta myosin heavy chain. So this is hypertrophic cardiomyopathy. In the vignette, when you find this condition, they will talk about a young athlete or a young patient who had a syncope during an exercise, and even may had a sudden cardiac death in young athlete due to ventricular arrhythmia. So hypertrophic cardiomyopathy may lead to ventricular arrhythmia, and this may lead to sudden cardiac death in a young athlete, or the other favorable. More favorable than this, of course. The patient may have syncope, just syncope during exercise, and you do echo and you will find hypertrophic cardiomyopathy. 60 to 70% of this is familial and autosomal dominant. So the finding, you remember, is S4, which is characteristic for hypertrophic cardiomyopathy, versus the S3, which is the characteristic of dilated cardiomyopathy. And you may kind of see mitral regurgitation due to impaired mitral valve closure, of course. So for the treatment here, it is not like dilated cardiomyopathy. Remember, in dilated cardiomyopathy, the main treatment is to decrease the fluid within the circulation. Dilated cardiomyopathy, you have to restrict the sodium. You have to give diuretic, mineralocorticoid receptor blocker. But here in hypertrophic cardiomyopathy, if you do that, you may make your patient die. So very important here on the counter. On the other hand, you have to avoid drugs that decrease the preload, such as diuretic and vasodilators. That was the treatment for dilated cardiomyopathy, and here it is contraindicated in hypertrophic cardiomyopathy. But you may give the patient beta blocker as in dilated cardiomyopathy, or non-dihydropyridine calcium channel blocker, such as verapamil. Also intracardiac device of high risk for the patient is the same. So this effect was the systolic dysfunction kind of thing, but hypertrophic cardiomyopathy is diastolic dysfunction. So we talked about the concentric hypertrophy and the sarcomeres adding in parallel, and even more predominant in the septum, not very high yield. So it is classified as hypertrophic obstructive cardiomyopathy when we say that hypertrophic cardiomyopathy has become a hypertrophic obstructive cardiomyopathy. This occurs when the left ventricular outflow tract is obstructed, and the hypertrophy is not essentially need to be symmetrical. They may be asymmetrical septal hypertrophy on the septum and the systolic anterior motion of the mitral valve. So the septum may obstruct the outflow of the heart. So this may cause outflow tract obstruction, and when this happens, this is called hypertrophic obstructive cardiomyopathy, or HOCM, hypertrophic obstructive cardiomyopathy, dyspnea, possible syncope. So for other causes of hypertrophic cardiomyopathy is chronic hypertension, of course, causes hypertrophic cardiomyopathy, or not called the hypertrophic cardiomyopathy, but it's called the concentric LV hypertrophy. So Friedreich's ataxia, very famous for that. We go through this in the biochemistry chapter. So Friedreich's ataxia, you know that for now it includes LV hypertrophy. So for the restrictive cardiomyopathy, the radiation, the patient may take radiation or radiotherapy may have on the long term restrictive cardiomyopathy. Loeffler endocarditis, you just have to know the name. It's related to eosinophilic or eosinophilic conditions such as parasites or malignancy. Any condition just involving eosinophils is called the Loeffler endocarditis. So he is associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates of the myocardium. Just know that. And the condition called endocardial fibroelastosis. Just know the name. So from the name, fibroelastic tissue in the endocardium, young children, so the demographic is young children, and the endocardium contains a thick fibroelastic tissue, so it's called endocardial fibroelastosis. So fibroelastosis in the endocardium of the child, so just know the name. Remember that first we said that sarcoidosis and hemochromatosis may cause both restrictive and dilated cardiomyopathy, so hemochromatosis, sarcoidosis, but amyloidosis only causes restrictive cardiomyopathy. So it's kind of also of a diastolic dysfunction. So all cause diastolic dysfunction. Hypertrophic cardiomyopathy, diastolic dysfunction. Restrictive cardiomyopathy, diastolic dysfunction. Only dilated cardiomyopathy causes systolic dysfunction, and the treatment is different. So sodium and diuretics, sodium restriction and diuretics. So restrictive cardiomyopathy, low voltage ECG, dyspneic myocardium. So there is a restriction of the myocardial beating, so the ECG waves essentially will be low. This is very logical, and you don't have a good contracting heart, especially in amyloidosis. It's very characteristic to have low voltage ECG. Our next topic is heart failure. So what is a heart failure after MI or after any other cause? The heart may just fails pumping and perfusing blood. So this is a kind of clinical syndrome of cardiac pump dysfunction. So it has two effects. The heart has to pump blood and supply all the body. So this will not happen. So you will have low perfusion. The other kind of effect is that the heart is going back. It's not going forward, so it has to go back, and if it goes back to the lung and causes kind of congestion. So this is the hallmark of the disease. So the symptoms include, of course, we have said first congestion and low perfusions are the two main categories. Dyspnea or dyspnea. So this is the congestion, dyspnea and dyspnea, and the low perfusion translates into fatigue. This is the symptoms. For the signs, SS3, heart sound, rails, jugular venous distension, rails on the lung, back pressure, jugular venous distension, also back pressure, and the translates into the external jugular vein, and beating edema. On a last stage may go backwards and to the venous system, up to the venous system of the legs, and cause beating edema. So it's subdivided into systolic dysfunction and diastolic dysfunction. Heart failure essentially doesn't need to be a systolic dysfunction, as we said here. Some have systolic dysfunction, others have diastolic dysfunction. So as for the systolic dysfunction, the heart failure with reduced ejection fraction, HFrEF, this is a systolic dysfunction. And if the heart failure has a reduced ejection fraction, that means the endodiastolic volume will be increased. The ejection fraction, the heart is not ejecting blood, so at the end of the diastole, there a lot of blood left over, so you will have increased endodiastolic volume. So and also decreased contractility at HFrEF. So this is often secondary to ischemia, MI, or dilated cardiomyopathy, as we have just mentioned that dilated cardiomyopathy has a systolic dysfunction. So this is the systolic dysfunction. The diastolic dysfunction is called HFpEF, preserved ejection fraction. So preserved ejection fractions, ejection fraction is preserved, so the endodiastolic volume is normal. So but here you have myocardial hypertrophy. You remember that for the hypertrophic cardiomyopathy. So you have myocardial hypertrophy, and the volume is normal, and the chambers are just hypertrophied and enlarged. So you will have a little space here. So this little space which have the same amount of the blood, this means the pressure will increase. So here in diastolic dysfunction, the effect is on the pressure. You will have increased in the diastolic pressure. So in systolic dysfunction, the volume will increase, while in the diastolic dysfunction, the pressure will increase, and the compliance will decrease. Of course, there is a hypertrophy, so there is no enough room. So This means that compliance will decrease. The right heart failure most often results from left heart failure. So, very famous question: what is the most common cause of right heart failure? It is left heart failure. If you have a left heart failure, there is a back pressure, eventually leading to right heart failure. But very famous, also very famous and high yield question is it is called core pulmonary. That means that isolated right heart failure. So the prototype right heart failure is right heart failure due to if left heart failure, but on a very specific conditions called core pulmonale, there is isolated right heart failure. So if you have isolated right heart failure, where is the defect? It is in the lung. So this is the left ventricle, this is the lung in between, and this is the right ventricle. So if you have a defect in the left ventricle, we transmit backwards through the lung and going through the right ventricle and causing right heart failure. But if you have isolated right heart failure, so the defect is in the middleman here. So the defect is in the lung, which is causing back pressure on the pulmonary artery and causing right heart failure. So this was called core pulmonale, which refers to isolated right heart failure due to pulmonary cause. So the treatment, all kind of treatment, ACE inhibitor, ARBs, ARNIs, angiotensin receptor neprilysin inhibitor, and for beta blockers. But you have to be very cautious in acute decompensated heart failure. If you have a patient in acute decompensated heart failure coming to the CCU, you don't have to, you need not to give the patient beta blocker contraindicated in the decompensated heart failure. But after he improves and goes on a home treatment prescription, you may give him back again beta blocker. So you have first to choose between ACE inhibitor, ARBs, or angiotensin receptor neprilysin inhibitor. It's kind of the same, and the beta blocker if except in acute decompensated heart failure, aldosterone receptor antagonists, of course, one of the first three ACE inhibitor, ARBs, and the angiotensin receptor neprilysin inhibitor plus beta blockers plus aldosterone receptor antagonists. Very high yield, that to know that the three, this kind of three drugs decrease the mortality, very high yield. But loop and thiazide diuretic, symptomatic relief, no effect on the mortality. I can't stress how high yield this point is. So you have to know which drugs decrease the mortality and which drugs are for symptomatic treatment on. And for hydralazine nitrate and SGLT2 sodium glucose cotransporter inhibitor, dapagliflozin and empagliflozin, these kind of drugs just improve both symptoms and mortality in selected patient, not a routine as the first drugs, but you may give hydrolyzine nitrate or give SGLT2 inhibitors, but they may have effect on mortality also. But these first drugs are high yield and very high yield to know that loop and thiazide diuretics, symptomatic relief, no effect on mortality. Left heart failure versus right heart failure. For the left heart failure, you will have orthopnea, paroxysmal nocturnal dyspnea. Orthopnea means chest tightness or lying flat, which is the same as paroxysmal nocturnal dyspnea, but paroxysmal nocturnal dyspnea relates more to being asleep. So you have when you go sleep, you become chest tightness, you wake up, and the cycle goes on and on. So orthopnea, paroxysmal nocturnal dyspnea, also orthopnea means the shortness of the breastplate in supine, increased venous return. You know, when you are supine, when you are erect, the blood pulls down in your legs due to the effect of the gravity, and when you lie supine, the effect of gravity wanes and the redistribution of blood occurs. So this exacerbates the pulmonary vascular conditions, orthopnea. Paroxysmal nocturnal dyspnea is the same, breathlessness, which awakes you from sleep, which is the same as orthopnea. Venous return from distribution of blood, of course, is the same. Reabsorption of peripheral edema. So this will leads finally to pulmonary edema, increased pulmonary venous pressure, increased pulmonary venous distension and transudation. If the pulmonary venous is distended, this will increase pressure, and this will lead to transudation of the fluid from the venous system or from the whatever to the lung itself. So this will lead in the long term to hemosiderin-laden macrophage cells or HF cells or hemosiderin-laden macrophage cells in the lung. For the right heart failure, congestive hepatomegaly, it is not very famous, a rare condition to see, but for increased central venous pressure will lead to transmission back into the liver. So this is called cardiac cirrhosis. You will have a condition called nutmeg liver on pathology, mottled appearance. You just know the names: congestive hepatomegaly, transmission backwards to the right ventricle, to the venous system, backwards to the liver, causing cardiac cirrhosis, and pathology is nutmeg liver. So jugular venous distension, of course, right ventricular failure causes right jugular venous distension. So the right ventricle causing back pressure into jugular system, we increase venous pressure, and the peripheral edema, of course. The left side of the heart transmits backwards to the lung, so you will have pulmonary edema. But the right side of the heart, you imagine it when transmitted backwards, it will transmit backwards to the peripheral system, so will cause peripheral edema. So and when it transmits to the jugular system, will cause jugular venous distension. When it transmits backwards to the liver, it will cause congestive hepatomegaly. So here's a scheme for the heart failure. So the heart failure starts by decreasing, you remember, decrease of the cardiac output. So the body will counteract by two systems, the sympathetic tone and the renin-angiotensin-aldosterone system. So the angiotensin and the aldosterone and ADH, and here's angiotensin and aldosterone. You know that angiotensin and ADH both have vasoconstriction effect. Angiotensin and ADH also have body water keeping effect, which increases the circulating volume. So the angiotensin 2 and aldosterone and the ADH, the three of them will increase the circulating volume. But aldosterone has no role in vasoconstriction. Only the angiotensin 2 and the ADH will cause vasoconstriction. So that you know that ADH acts on two receptor, on a V1 or a V2. The V1 causes vasoconstriction, or ADH action on a V2 causes a receptor increases circulating volume. So the ADH is famous for increasing the circulating system, which called antidiuretic hormone, but also it has a vasoconstrictor effect when it acts on the V1 receptor. Very high, you know that. But and the angiotensin, on the other hand, is famous for causing vasoconstriction, but it causes that on a angiotensin 1 receptor, and it also causes increasing circulating volume. Aldosterone, of course, is famous for causing increasing circulating volume, but it only does that. So the trick here is the antidiuretic hormone. It has a vasoconstrictor effect. So when you increase the circulating volume, increasing the venous return to the heart, which is the preload. And if you increase the preload according to Starling mechanism, you are increasing the stroke volume, which will maintain the cardiac output. And you started by decrease cardiac output. We go there to come back to maintenance of cardiac output and the maintenance of the blood pressure. This is the first pathway. Second pathway by angiotensin 2, the angiotensin 1 receptor and the antidiuretic hormone on the V1 receptor. We are here causing a vasoconstriction, which will increase both venous tone, which increase venous return and gives the same effect, and increase arterial tone and maintain blood pressure and maintain cardiac output. This is for the renin-angiotensin aldosterone, and this effect through angiotensin 2 and antidiuretic hormone and aldosterone. On the other hand, the sympathetic tone and H effect through catecholamine alpha 1 and the catecholamine beta 1. The alpha 1, of course, it is known it causes vasoconstriction, the same effect as angiotensin 2 and ADH from renin-angiotensin aldosterone system pathway. And for the other effect is through B1. The B1 increases both contractility and the heart rate. Increases the cardiac heart rate is will lead to maintenance of cardiac output and the maintenance of blood pressure, and increasing the contractility will increase the stroke volume and maintain cardiac output. You maintain cardiac output either by increasing heart rate or increasing the contractility, and then increasing the stroke volume. So it's very logical. So here for is a graph for heart failure reduced ejection fraction and the heart failure preserved ejection fraction. So for the heart failure reduced ejection fraction, you know that this is the original curve and it is shifted to the right. So reduced ejection fraction will have more volume. So on a volume curve you are shifting the this graph to the right. So you